Merck, and I'm joined by my colleague Julie Zaharados as well. We're both on the maternal mortality prevention team, which is in CDC's Division of Reproductive Health. And we're going to be talking today about our work on national approaches to prevent pregnancy-related deaths. So just as an overview of our discussion, we'll be sharing some national maternal mortality data, emphasizing and kind of resharing some of the pieces that Maddie shared a little while ago. We'll talk about the work that goes into reviewing pregnancy-associated deaths, which are deaths temporally associated with pregnancy, so during pregnancy or within a year of pregnancy. We'll talk about the support that we provide to maternal mortality review committees, and kind of the strengths of maternal mortality review committees. And then we'll close with some information about taking data to action. So really kind of the goal of maternal mortality review committees is to generate an evidence base in order to take action and prevent future pregnancy-related deaths. We'll close with some sharing some information about our path forward. So to reshare some of the key data that Maddie shared earlier, this is information about pregnancy-related deaths, that overall each year about 700 women die during or within 1 year of the end of pregnancy in the US as a result of pregnancy or delivery complications. And there are considerable and persistent disparities, racial disparities contained within that number. American Indian, Alaska Native, and Black women were 2 to 3 times more likely, respectively, to die of pregnancy-related causes than white women. And data from maternal mortality review committees indicate that indeed about 2 in 3 of these deaths may be preventable. This slide shares the distribution of Native pregnancy-related deaths across 5 types of geography from CDC's Pregnancy Mortality Surveillance System. And this slide shows that about half occur in rural areas, and that is about twice that of any other racial or ethnic group in rural areas. And this speaks particularly to an important need to focus on rural areas to prevent Native pregnancy-related deaths. On this slide, showing the leading causes of pregnancy-related death among Native persons, again from the Pregnancy Mortality Surveillance System, we can see that hemorrhage and cardiomyopathy are at the top of the leading causes. And this information can be used to begin thinking about priorities and approaches for preventing deaths among Native persons. But of note, and because of limitations of vital records that the Pregnancy Mortality Surveillance System is based upon, injury deaths are excluded. But from maternal mortality review committees, which I will talk about in subsequent slides, we're able to use much broader sources of information, and we know actually that mental health conditions are a leading cause of pregnancy-related deaths in the United States. So with these data in mind, the question that our team, the maternal mortality prevention team at CDC, is called to answer is how can we effectively address maternal mortality in the United States and prevent future tragic deaths of birthing people? And secondly, how can we ensure that the data are used to inform and drive maternal health initiatives that maximize impact and reduce disparities? Our answer to both of those questions are maternal mortality review committees. Maternal mortality review committees, again, as Maddie shared a little bit of an overview before, they seek to provide a deep understanding of maternal mortality through understanding both the medical and non-medical contributors to deaths and developing and prioritizing recommendations to prevent future deaths. The data slides I displayed earlier tell us important information about leading causes and geographic distributions of pregnancy-related deaths, but MMRCs really provide critical details. And they do this by reviewing not just death certificates and any linked birth or fetal death certificates, but also medical records, social services records, mental health records, autopsy reports, and in some cases, informant interviews. These maternal mortality review committees include representatives from public health, obstetrics and gynecology, maternal and fetal medicine, nursing, midwifery, forensic pathology, social work, mental health and behavioral health, as well as members of the community represented by the Maternal Mortality Review Committee. And the promise of maternal mortality review committees is really to dive deeply into the data and into the cases, and to do so within the local context. So importantly to note, maternal mortality review is an ongoing, anonymous, and confidential process of data collection, analysis, interpretation, and action. It's a systematic process that's guided by policy, statutes, and rules, and it's really intended to move from data collection to action, to prevention activities. And it is not a mechanism for assigning blame or responsibility for death. It is not a research study. It's not a peer review, an institutional review, nor a substitute for existing mortality and morbidity inquiries. It's really focused on this kind of public health approach of preventing pregnancy-related deaths. There's been a much growth in maternal mortality review committees over time. Most, but not all states have an active maternal mortality review committee collecting comparable data on pregnancy-related deaths. Currently, there are 50 existing reviews in the United States, and that's 47 states, 2 cities, and Washington, D.C., which represents significant progress since 2015, as you can see on this slide. At that time in 2015, there were roughly 20 existing MMRCs. This journey really began in 2013 when several states were piloting CDC's MMRDS, and states were participating in AMCHIP's Every Mother initiative. But since then, the program has evolved to include data collection around critical areas of need, including cardiac contributors to maternal mortality, including overdose deaths, and including around critical areas, including social determinants of health as well. In 2016, Merck for Mothers funded a public-private partnership with CDC, the CDC Foundation, and AMCHIP to launch Building U.S. Capacity to Review and Prevent Maternal Deaths. A central part of this effort was the launch of the Maternal Mortality Review Information Application, or MMRIA, as well as the Review to Action website. 2017, the Review to Action website, which is a collaborative platform for maternal mortality review committee resource sharing, was launched. And this was launched in partnership with AMCHIP. This website really serves as a learning and resource hub for maternal mortality review committees nationally. 2017 also marked the first MMRIA user meeting, which we've held every year since. Then in 2019, the Enhancing Reviews and Surveillance to Eliminate Maternal Mortality, or ERASE program, was launched. CDC made awards supporting 25 states for ERASE, which provides direct support to maternal mortality review committees. And in this past year, with appropriations from Congress, we were able to fund additional states through the ERASE program. So the ERASE Maternal Mortality Program is now in its 3rd year, and with those additional funds, we are now directly funding 30 jurisdictions, which supports review programs in 31 states. CDC funding supports coordination and management of maternal mortality review committee programs, which in turn leads to the identification, review, and characterization of pregnancy-associated deaths and identification of opportunities to prevent future deaths. Through ERASE Maternal Mortality, we support teams to do all of the things on this slide with the ultimate goal of preventing similar deaths in the future. We also help teams improve the quality and timeliness of data and provide technical assistance on data analysis so that they can share their findings to inform prevention strategies. And I would also note that our support extends to states that are not funded by ERASE in some of their work to identify, review, and document opportunities to prevent maternal mortality. So ultimately, this activity supports a national approach to collecting and sharing data on maternal mortality. In working with states, we found the one thing that they really needed was a standardized data system available to support essential review functions and to analyze data across jurisdictions. So we developed the Maternal Mortality Review Information Application, or MMRIA, to support essential functions such as data abstraction, case narrative development, documentations of the decisions that the committees are making, as well as analysis. MMRIA is bringing together data across jurisdictions so that we not only have a better idea of what the data look like at the state level, but we also have a better picture of what's happening throughout the country. These data will facilitate an understanding of the drivers of maternal mortality and the complications of pregnancy and associated disparities. It'll help us determine what interventions have the most impact at patient, provider, facility, system, and community levels. And also the data will help identify initiatives to implement in the right places for families and communities that need them most. Since MMRIA launched in 2017, the number of jurisdictions using our common language and contributing to an aggregate learning has grown. We started with a 4-state report, and most recently we were able to put out a data brief based on 14 state MMRC data. And we're really excited that recently we issued our first national call for data that will include data shared by 36 jurisdictions. And we plan to share information from the analyses of these data later this year. So MMRIA has really been instrumental in helping us gain a deeper understanding of maternal mortality. For instance, using MMRIA, we were able to look at Maternal Mortality Review Committee data from 14 states and found that mental health conditions are the leading cause of preventable pregnancy-related deaths. But a significant strength of MMRIA data is to go beyond the quantitative data. We can use qualitative analysis for a deeper understanding of maternal mortality. The arrows on the left side of this graphic represent factors that contributed to substance use disorder deaths, and the boxes on the right are actual recommendations made by maternal mortality review committees to individually address these contributing factors and prevent future deaths. One contributing factor, as identified by an MMRC, was that the decedent did not go to a substance use treatment facility despite having a referral. And to address this, the MMRC recommended providing access to treatment on demand without requiring a positive toxicology screen to enter detox. And another contributing factor noted on this slide was that access to a substance use treatment facility was 50 miles from a person's residence. So the recommendation was for the state to locate treatment facilities within close proximity to and accessible to pregnant persons. It's really in these qualitative data that we can start to examine common themes and prioritize recommendations to prevent future pregnancy-related deaths. In addition to providing data that can contribute to national analyses, MMRIA supports jurisdiction-level analyses, more local analyses. In the first year of Erase MM, CDC-funded jurisdictions reported 23 total MMRIA analyses, and in the second year of Erase MM, jurisdictions reported 82 total MMRIA analyses. These data analyses, again, provide the evidence base to prevent future pregnancy-related deaths. Taking action is the ultimate goal from these MMRIA analyses, as every single case that maternal mortality review committees have reviewed and will review is a tragedy that reverberates. And that reminds us of our important charge to eliminate preventable maternal mortality and reduce disparities. I'll share a few examples of MMRIA data to action in this and subsequent slides. So in April 2021, Illinois became the first state in the US to extend full Medicaid coverage to people who just gave birth from 60 days to 1 year postpartum. This policy implementation was based on the key recommendation made by the Illinois Maternal Mortality Review Committees in their 2018 report. And that report showed 1/3 of pregnancy-related deaths occur later than 43 days postpartum, and showed that access to care throughout 1 year postpartum is vital to preventing maternal deaths. The second example comes from Wisconsin that reflects improvements made to the process for identifying pregnancy-associated deaths, which enabled the state team to learn important information about COVID-19 deaths among pregnant and postpartum persons. The Wisconsin MMRC identified a recent increase in the number of recently pregnant people who have died from COVID-19 in Wisconsin. These deaths occurred in people who were unvaccinated and who developed COVID-19 disease during pregnancy, which resulted in either early delivery or miscarriage. In some cases, the infant did not survive. So in partnership with the Wisconsin Department of Health Services leadership, the Wisconsin Maternal Mortality Review Program helped to write and release a health alert through the Health Alert Network to encourage urgent efforts to vaccinate and boost people who are pregnant, recently pregnant, who are trying to get pregnant, and who might become pregnant in the future. And the Utah Maternal Mental Health Resource Network is something that was developed in response to the Utah Maternal Mortality Review Committee recommendation to educate providers on available resources and mental health specialists they can refer to, as well as data from other sources, such as the Pregnancy Risk Assessment Monitoring System. So Utah, alongside several community partners and legislators, gathered at the Utah State Capitol building on February 25th, 2020, to announce the launch of this website. And in the first month of the launch, the website received 1,300 visitors. Utah also established an Instagram page to share information about pregnancy and life postpartum, emphasizing the message, "You are not alone." So here are 3 posts from that Instagram account, which is at Maternal Mental Health Utah, if you want to check it out. So with that kind of background, I'd like to turn it over to my colleague, Julie Zaharatos, to talk about the path forward.
Thank you, Toby. You can go on to the next slide, please. We wanted to share that, we've been working with jurisdictions who've been reviewing maternal mortalities and providing some job aids to them as they do their work. This is a long list. Many of these can be found on our website at review2action.org. My key point here is that many process resources are available to those who want to review deaths. And we are continually updating these resources as we learn from those who are reviewing deaths. And so you can check them out on our website. And again, I'll drop the link here in the chat so that you can look at them as well. But we're continuing to work to address some known gaps here. And some of you may have some of these already in mind. Go to the next slide, please. So we're working to support maternal mortality review processes and new approaches. So specifically informant interviews or survivor interviews, working with her next of kin to understand more of her perspective. We're also working to document the contributors of discrimination and racism. And as you know, and what Maddie and Toby and others have talked about is at the upper right here, tribally led partnerships. And also mentioned here is community vital signs. We're working to understand community context better. What are the structural resources and also structural barriers that are in her individual community? Digging a little deeper into those informant interviews or survivor interviews, these offer additional context. Again, if just the medical records alone are reviewed, it's really just an external perspective. And it's really important for us to try to understand the perspective and the lived experience of the person who passed away. And you can see here that those informants could be a partner or a family member or a close friend. And it's an important way to incorporate lived experience We did hear from one review team that now that they include these informant interviews, they can't imagine reviewing cases without them. There's just so much that the medical record cannot tell you. And, you know, we could spend a long time talking about these things, but we just wanted to mention again that this data system and data strategy, MMRIA, the Maternal Mortality Review Information Application, can be used to document discrimination and racism. And we're also diving deeply into some additional resources to help reviewers with this. We had a MMRIA user meeting last year where there was a presentation on structural racism and an equity-centered future for maternal mortality review committees. I just dropped the link in the chat. We're also working with national partners at the American College of Obstetricians and Gynecologists, or ACOG, to develop a tool to document an event of interpersonal racism or discrimination. We also have a partnership with Black Mamas Matter Alliance, looking at increasing community engagement in maternal mortality review. Our partners at BMMA recently put out a report, and you can visit the link on their website. I just dropped it in the chat. We're also working with the National Birth Equity Collaborative to look at some of the early data from MMRIA users on those discrimination checkboxes and the new contributing factors around discrimination and racism. And lastly, we host monthly office hours with MMRIA users, the nurse abstractors and the coordinators, to share their existing state approaches and to learn from one another and ask questions of one another as we all continue on this anti-racism journey. We go to the next slide. I mentioned briefly community vital signs indicators. So pulling in her county level context can be really helpful. So looking at community health indicators where the pregnant or postpartum person lived compared to those of all other pregnant or postpartum persons in the same state or nationally. So looking at things like access to obstetric providers, nurses, and also understanding access to car and transportation and things like that. And we will have vital signs dashboards integrated into this MMRIA data system this year. And that project has been supported in partnership with the Office of Minority Health and with Emory University. And this is the second to last slide, so we're almost there. So last but certainly not least in this CDC presentation is respecting tribal sovereignty and data sovereignty. And so I think, as has been discussed, and I'm seeing comments in the chat, Native populations face a significant maternal mortality burden. And while maternal mortality review committees have the capacity to identify and implement prevention strategies, there are currently no tribally led MMRCs, and too few state-based MMRCs have tribal representation. So while having tribes represented on state MMRCs is important, it doesn't equate to led maternal mortality review committees that serve Native persons' needs. And to achieve that goal, we are beginning this work with National Indian Health Board. And so as Maddie showed, there is the logic model and other pieces that are coming together. And we know you are working with tribes and tribal organizations to explore key components of a tribally led MMRCs and assess readiness and to establish and sustain a tribally led maternal mortality review committee. So currently we are planning for scale and learning from you all and NIHB on the readiness assessment. We're also learning from state programs who are working to incorporate tribal voices into their programs and hosting listening sessions with tribal organizations to understand how maternal mortality review committee data may be reported or used to advance our collective public health goals. Ultimately, the focus of our work is to support the foundations necessary for implementing tribally led maternal mortality review committees that respect Native culture and result in meaningful and effective prevention strategies for Native communities. And with that, we'll close our presentation, and we're happy to transition to the next part where we can discuss.
Sure thing. Thank you so much, Toby and Julie. We really appreciate you being here and sharing that information and setting up the context in which maternal mortality review committees can exist at a tribal level. That was very informative, so thank you. And let's see, so we do have a panel and discussion built into this panel. It's scheduled to start at 2:30. So I think if it's okay with everyone, we will take a break and we can think about questions we have for our panel experts. And then Nina, she's raising her hand.
Maddie, I was just going to say, since we're running a little ahead of schedule, there are a couple questions in the chat specifically pertaining to the CDC presentation that might be good to have a little bit of time for.
Yes, absolutely. Yeah, so do you feel comfortable being able to read those out? I can't.
Yes. Yeah.
Okay,
yeah.
Thank you.
Let me go back up. I know some of the first ones that I saw were around the slides around mental health. Specifically, there is one from Teresa about whether the mental health issues captured are prior to pregnancy or discovered with a new diagnosis during the course of pregnancy. And then there is another comment right after that from Gretchen on whether you can comment a bit more about mental health as a cause of death specifically. And are you talking specifically about substance use disorder related deaths or accidents, suicide, or other, what is under that mental health as a cause of death definition?
Thanks, Nina, and thanks for the questions. So I just chatted. I can share the link to the article that that our colleagues published in Health Affairs. But the definition for pregnancy-related health, pregnancy-related due to mental health conditions is copied here in the chat. But they were defined as any pregnancy-related death for which the Maternal Mortality Review Committee assigned mental health conditions, depression, or other psychiatric conditions as the underlying cause of death, including all suicides as well as overdoses of unintentional or unknown intent where substance use disorder was indicated. And this would, since maternal mortality review committees have access to a broad swath of records, not just vital records that would include the cause of death information. They have access to social services records and mental health records or behavioral health records to then go in and make sure that kind of what the committee is deciding has committee consensus around. So if they do feel like there was a mental health condition that contributed to the death that they see in that individual case from the records that are available and abstracted, then they can feel confident about making that decision on that particular piece. Same thing with substance use disorder. So encouraging committees to look at if there is a documented substance use disorder in the records, or if the committee, and we also encourage a committee to have experts sitting on the committee that are experts in substance use disorders and can also review the records and speak to whether or not there may have been a substance use disorder present in that case. Hope that answers the question. I'm seeing one that just popped up, and this is an easy one. In addition to SMEs, do community members participate on MMRCs? That absolutely, and it's actually something that we're encouraging committees to consider how community member participation representation can advance on MMRCs. So the short answer is yes. Nina, I'll turn it back to you if you wanted to pull a few other questions out.
Yeah, and just as a note for everybody here today too, we know there sometimes are more questions than we have time, so we will make sure for anything that doesn't get addressed that we'll follow back up with the folks posting them with some information after. So just letting everybody know that. There was another question that I think was kind of tied to that definition piece around mental health. And I saw another comment that just came up as well from Dr. Palacios. I think, and please, Dr. Palacios or the others in this conversation, correct me if this isn't quite specific. But I think expanding beyond mental health and then looking at that connection to violence, to intimate partner violence, and understanding how that might be captured in how an MMRC might capture the relationship between domestic violence or intimate partner violence or other forms of violence that a pregnant person may experience, and the impact on their birth and such.
Yeah, so homicide. So when I talked a little bit about the pregnancy mortality surveillance system, PMSS, and I mentioned that PMSS excludes injury deaths. So that would include homicides or overdoses. One of the strengths of the maternal mortality review committees is that they can review any death that occurs during pregnancy or within a year of pregnancy because they have access to those, or oftentimes they have access to those deeper sources and additional sources of information about the life of the person and the care the person the care that the person received before they died. Oftentimes, as Julie mentioned, informant interviews can also be very key in learning about what challenges or opportunities or lack of opportunities or experiences with medical care or lack of experiences with medical care that a person had. So if a committee is reviewing a homicide death and it's determined, the committee would then look at that death and try to determine if the death is pregnancy related. So asking the question, would this death have occurred if the individual were not pregnant? And if so, then thinking through what are those factors that contributed to the death and what are the opportunities to prevent future deaths. So it is feasible that a committee could be reviewing a homicide death, determine it's pregnancy related, and then think through kind of what are those ways that those deaths can be prevented in the future.
Thank you for that, Toby. There was one more conversation thread that I could pull out right now, is that there are some questions and comments around underreporting of maternal mortality, and then, well, actually two halves of that, underreporting overall of maternal mortality deaths. One specifically around deaths outside of obstetric systems and how deaths are being recorded as pregnancy related. So Hannah asked, what are the barriers to expanding reporting accuracy and catching more cases that may occur? And then I will come back to the second one.
Thanks, Dina. It's a great question. And what we know is that just looking at vital records and looking at the pregnancy checkbox on the death certificate is not the best way to make sure that the universe of pregnancy associated deaths are recorded. There are errors with the pregnancy checkbox on the death certificate that have been documented in various ways. So one of the ways that we work with maternal mortality review committees to improve the identification of pregnancy associated deaths is to not just look at the pregnancy checkbox, but to actually link a death certificate with a birth or fetal death certificate to confirm that pregnancy. And if a birth or fetal death certificate is not available, to look at actual literal text on the death certificate to make sure that that the certifier who was filling out the death certificate meant to check the pregnancy checkbox if it was a death from a pregnancy complication. And sometimes that literal information can be included on the death certificate. Or there are some other ways that we've encouraged states to think about linking their vital records, their death certificates, to additional information to ensure that they're looking at the right cases and then reviewing the right cases for pregnancy-related deaths.
And then Hannah actually had a follow-up, is also how that might apply to deaths that are a little further from, perhaps closer to a year out from birth.
Yeah, so that's where I think looking at the best way to identify would be having that access to the birth certificate or the fetal death certificate as well, so that that when the linkage is done, it's clear that the pregnancy-associated death, that a program is wanting to confirm that the person was actually pregnant or was pregnant within a year of death. That's kind of the first kind of identification method that we provide technical assistance on with 2 states to help support. But then, as I mentioned, there are some additional sources or additional methods to make sure that their states are capturing kind of the universe of pregnancy-associated deaths during pregnancy or within a year of pregnancy.
Thank you. And so the other half of kind of the earlier question about underreporting of maternal deaths is related to a topic that we talk a lot about at NIHB, not just with our maternal health programs, but across all data-related projects, is about racial misclassification and how that contributes to the potential underreporting or misclassification of the deaths of Native mothers. And so if you can share a little bit more, and we may also get to this in the section specific to data later today, but just if we can talk a little bit more about how MMRCs might be able to address some of that potential misclassification that we know can come with mortality records.
Yeah, thanks, Nina. And I don't want to take anything away if there's going to be future discussion on this as well in subsequent sessions. But I did want to note that in thinking again through the some of the data analysis guidance that we give analysts and epidemiologists is thinking about first going to the birth certificate for the mother's race and ethnicity, because that would be a self-report, a self-identification on the birth certificate, versus looking at a death certificate where it would not be self-identified race and ethnicity. So that's kind of the first piece there. We are aware of the racial misclassification challenges, and particularly the challenges of misclassifying American Indian and Alaska Native persons on death certificates. And one of the areas that we hope to kind of work toward in the future, as we are thinking about, as we're really kind of doing some of this formative work in partnership with NIHB and thinking through how we can move this formative work forward, and envisioning a tribal-led MMRC is also thinking through how can we ensure that we're doing everything we can to reduce misclassification when we're analyzing our data sets. So we have a few ideas. I know that the National Portland Indian Health Board has done some work in this area. So we're excited to learn more and to kind of work toward that challenge.
Absolutely, and it is certainly something that we are thinking about too at NIHB, and that we've heard come up in a number of conversations. As you know, as Maddie has brought up, this is a new process. We are also working with tribes and tribal organizations to figure out what MMRCs that serve tribes could look like. And we know that the data component is going to be a huge portion of that conversation. So we are equally invested in trying to understand how systems can be set up to honor tribal data sovereignty, and really ensure that people are captured appropriately, and really make sure that we can make these things visible. See if there are any other questions in the chat. Everybody has so many great comments. It just keeps going up 15 comments by the time we get through one question. Okay, I see Julie posted some links. There's a question about whether MMRCs have access to medical records beyond a death certificate. Yeah.
Yeah, absolutely. The maternal mortality, really one of the strengths of the Maternal Mortality Review Committee process is that they do have access to more records than just the vital records, more records than just the death certificate or the birth certificate, the fetal death certificate. So they might have access to social service records, behavioral health, mental health records, and other other medical records as well. So it's certainly not just the vital records piece. It's a wide variety of records.
Great, thank you. I think that's all of the questions that I see so far. Oh, somebody just asked, only 2 states have Indigenous representation on state MMRCs, and if you can specify what states those are.
I'm not sure that I mentioned that there were only 2 states have Indigenous representation on MMRCs. If I mentioned that, my mistake. I apologize for that. I would probably defer to the next panel to talk about growing representation on MMRCs among American Indian Alaska Native communities. But it is something that we are working toward with states to think about. When I was talking earlier about this idea of having subject matter experts, and subject matter experts meaning subject matter expertise in clinical and non-clinical areas, but also in addition to that kind of multidisciplinary background and perspective of the MMRC, also having an MMRC that is diverse and that's representative of the communities that it is that it's serving. So it is something thinking through how to support states in recruitment and in growing their representation, their multidisciplinary representation, as well as their community and representativeness overall is something that we're focused on here. I'm seeing another question here. Sorry, Nina, I'm taking your away.
No, go ahead.
Okay. I am seeing a question from Kate. Currently, only 11 jurisdictions have reported pregnancy-associated deaths of AIAN individuals. Any plans for aggregated data or other improved reporting from or within NAHB or CDC? I can speak to the CDC part. So we are, as I mentioned, we are excited that we will soon be able to release information from our from 36 states. It'll be a national analysis from including data from 36 states, and we will be able to include some information about pregnancy-related deaths among American Indian Alaska Native communities within that national data set.
Great. These are all wonderful questions. Thank you, Nina, for facilitating that Q&A for just a second. And thank you, Toby and Julie, for sticking around. If you want, you can stay, but we don't. If you're busy, that's also fine. I think we're going to now